I'm Dr. Madhara Rajapakse, histopathology registrar, National Hospital Goa, Sri Lanka. I'm going to present a case about a 14-year-old girl who had a parathyroid adenoma, and she presented in an unusual way to the hospital, and the histopathological diagnosis of this patient turned the case towards the correct diagnosis ultimately. Parathyroid adenoma is the major cause of primary hyperparathyroidism in pediatric population as well as in adults. But the incidence of parathyroid adenoma are very low in kids. Most of the parathyroid adenomas are sporadic, but syndromic association should be considered, especially in the pediatric population. This case is about a 14-year-old girl. She was a previously healthy girl. She developed a progressive hip pain followed by a limp following a sudden fall. She was brought to hospital by her parents. Before that, they have taken the child into several Ayurvedic doctors. So, by the time she reached to the orthopedic surgeon, his consideration was this could be a osteosarcoma or a Nevin sarcoma. She underwent a CECT which showed generalized osteopenia with a comminuted fracture in left femoral neck. She underwent MRI by a veteran radiologist in the country, which suggested the possibility of chronic osteomyelitis. So the surgeon had diagnosed a dilemma, and he decided to take biopsies and take the histopathology opinion too. We received multiple bone fragments as the biopsy specimen, which were very soft and fragile and easily resectable by a scalpel blade. So, the microscopy of this bone fragment showed irregular disorganized trabeculae of woven bone with conspicuous osteoblastic remain in a fibroscalar stroma. Osteoclastic giant cells were focally seen, and there were no evidence of significant chronic inflammatory cell infiltrate suggestive of chronic osteomyelitis. And there were no atypical cells, no bizarre giant cells, or no small round cells suggestive of a malignancy. So where was the pathology? We had the suspicion of that this could be a mineralization defect in this child. So we contacted the surgical team again, and we did a bone profile on this patient. So the parathyroid hormone levels was very high in this patient with high serum calcium and high serum alkaline phosphatase levels. Her serum vitamin D level was low. So all these pointed towards the possibility of parathyroid adenoma, which was confirmed by the CT scan of the neck and system scan. Patient underwent excision of parathyroid adenoma, and we received death sample too, which was a well-circumscribed lump with homogeneously pale and cut surfaces. The microscopy of this parathyroid adenoma showed a well-circumscribed capsulated lesion which is composed of a monotonous population of chief cells arranged in nest sheaths and trabeculae. Thin, delicate fibrous septae and scattered capillaries were also seen within the lesion. And there was no significant nuclear atypia, mitosis or necrosis, and there was no capsular vascular invasion. Following the resection of parathyroid adenoma, patient improved drastically, and she is awaiting for the total hip replacement therapy. So what are the learning points of this case? First one, when a patient presents with a pathological fracture, our first diagnosis is towards a malignancy. Could be a primary bone cancer or could be a metastatic deposit. But even in adult or even in a kid, we have to always keep in mind the possibility of calcium metabolism defect, which can lead to pathological fractures, especially in the pediatric population as well as in the presence of multiple bone fractures. And this primary hyperparathyroidism could be a presentation of a hereditary cancer syndrome, which includes parathyroid adenomas such as multiple endocrine neoplasia 1, isolated familial hyperparathyroidism syndrome, and hyperparathyroidism, jaw tumor syndrome, and etc. We have to always keep in mind this could be a first presentation of a hereditary cancer syndrome. And the other thing is, if a patient presents with a bone lesion, it is always best to have an idea about the radiological diagnosis, and if needed, go for a multidisciplinary team discussion for a accurate diagnosis, just like in this case. The patient is now doing well, and histopathology was the turning point towards the correct diagnosis in this case. Thank you.